If I can have all our speakers, please. It is, as Carol mentioned, it is extremely important, this issue of communication. As a matter of fact, not just our patients need to learn, are encouraged to communicate with physicians. Actually, we have to go through a 6-hour course how to communicate and how to listen to our patients. So it is kind of mandatory at the Cleveland Clinic. In the beginning, we thought that, we know how to communicate with our patients. And later on, we learned that, we didn't know anything. Okay, let's see. Okay, I think the first question is for Sang. Why can't bile duct have stents inserted that stay in place, much like cardiac stents, permanent stents or something?
So to answer that question, actually, I did not go over, but there are two types of stents. One is called the plastic, the other called metal stents. So the metal stents tend to stay longer. However, they both are meant for the metal stents traditionally was developed for the palliative purpose. So for that metal stent, the intent and purpose was to stay there. I think the physiologic explanation for the metal stent in terms of, or the stents in the coronary versus the bile duct is actually has a lot to do with the flow and circulation. The circulations of a cardiovascular system is continuous, ongoing. If it doesn't, then you're in trouble, right? Whereas the bile duct circulation is not. It really is not a circulation, if you will. It's a one-directional flow. So there is a difference in terms of the buildup of residues and the complications in terms of the mass amount of the aggregation of this clogging debris, which causes actually cholangitis itself. At the end of the day, the mantra is your body always wins. So if you don't have a continuous flow, the sedimentation will happen regardless, and it's a matter of time. The metal stent is bigger, so it takes a little more time. Plastic stent is a lot smaller. That's why you cannot have stent there permanently. And finally, let's just also say the stent itself is not a prevention for a cholangiocarcinoma. So those things can happen alongside of stent. How would you know if you have a stent in there and development of a cholangiocarcinoma in the absence of a good picture? You can't.
Okay, this is another interesting question probably for you or Sang. It's my understanding that a patient who had a transplant cannot have an ERCP to diagnose I think is recurrent PSC. Is that true?
No.
Well, the reason I know where this question is coming from. Most of the patients who get a transplant for PSC, they get a Roux-en-Y, and that could be a limiting factor that sometimes ERCP, you cannot have an ERCP through all the length of Roux limb and go back to the bile duct and get to that. So that could be the reason. I'm not sure if I answered the question or not. But go ahead, sir.
Traditional liver transplant is, you guys give me the same access. That's why I like it. So yeah, to answer that question, I think what some are referring is actually the necessity of the ERCP or potential dangers of it. But anatomically speaking, unless, as Bijan mentioned, there is an alteration where the bile duct comes out, in itself is not indicated. Quite frankly, actually, there are patients that we have to do ERCP on liver transplant patients for anastomotic strictures, which also is another completely different matter. But I think my first answer was kind of self-satisfactory. No.
Well, actually, it's not that it's a rule of transplant to do ERCP, to do Roux-en-Y hepatic jejunectomy in every single patient who is getting a transplant for PSC. We look at the bile duct. If the bile duct is clean, not all the patients with PSC have a common bile duct disease. They have intrahepatic disease, but the extrahepatic bile duct is clean. And we do duct-to-duct anastomosis. We can use the patient's own bile duct to hook it up to the new liver. So in the past, it was a rule that written on stone that every patient with PSC should get hepatic jejunectomy But that is not the rule anymore. If the bile duct is clean, we can just use the bile duct of the patient. And in that case, ERCP is a common procedure that we do, and it's very easy to be done. Okay. Let's see. There are too many questions coming in, but that's good. The question just about sleep aids. What? Just a question. It's a sleep aid, so if I can help.
So that's a broad question. So there are different variety of sleep aids. What we say are traditional sleep aids is benzodiazepines. Somewhat newer sleep aids is benzodiazepine receptor agonists, where zolpidem, zaleplon, and the trade names are Ambien and Sonata fall into that category. Some of the other sleep aids, which are not really a sleep aids, but the side effect is sleepiness is oftentimes used, which is such as trazodone and other antidepressants which can be used. Doxepin is other sleep aid which could be used. And then there are over-the-counter medications which can be used. Some people use diphenhydramine or antihistamines as a sleep aid, which I don't recommend, although it can be used for other reasons. The reason being because of the long half-life, and it stays in your body for a long time and can promote grogginess and so forth. So with these sleep aids, however, you always have to be cautious about the side effects and the metabolism, especially through the liver disease. They can promote drowsiness, the risk of drowsy driving the next day, the risk of falls, the risk of fractures. Some sleep-related behaviors have been reported with the sleep aids, such as sleepwalking and pathological behaviors, and so many other variety of side effects, the risk of dependency, tolerance, and so forth. So in general, we try to look at the root cause of the problem, root cause of insomnia. As I said, insomnia oftentimes is associated with some sort of underlying cause, either be it medical illness, be it a psychiatric illness. So we try to tackle that first. Or other sleep disorders can contribute to insomnia. For instance, sleep apnea patients can have a lot of nighttime awakenings. Restless legs patients who have difficulty falling asleep and even difficulty maintaining sleep. So we often probe down to these sleep disorders, and we try to treat those sleep disorders. So that's our approach, generally speaking. And then, despite that, if there is no benefit and somebody who has insomnia and there's no reason for it, we try to refer them to non-pharmacological ways of treatment, that is non-sleep aids way of treatment that I referred to earlier in my presentation, which is a cognitive behavioral therapy for insomnia, given the fact that it's safe, effective, and have long-lasting effects. We do give it, but for a shorter period of time, taking into account the risk factors and so forth, but for a short duration if possible. And given the fact that there's a whole host of side effects that we have to worry about.
There is, if I read it correctly, Dr. I think it's for you, Sam. Please comment on the cleaning challenges with the ERCP scopes.
Whoever came up with that question, I applaud your knowledge and insight to this matter. Indeed, actually, it's one of those topics that actually requires attention at the same time. If you go back to the original inciting event, in itself it stems from a single, if not a few events. Actually, I believe, I'm not mistaken, it started from the UCLA. The whole point about, you guys saw the picture of the side viewing channel. So the cleaning process, the aspects of the scope basically involves the channel, the working channel being brushed thoroughly, being disinfected, and hung up in the proper places. When this came to a light, and then there was actually other anecdotal incidents of it, institutions like ourselves actually did a root cause analysis. So for example, let me tell you, at least from what our institution does, we have a very specific a mechanism at this point that those front viewing scopes, so-called the EGD scopes and colonoscopes, we have our own cleaning team and facility within our endoscopy suite, where actually we do the cleansings and make sure that each scope is well hung, well dry in the places that is approved by the CMS as well. For the side viewing duodenoscope as such, what we have done is we decide to bring those things to our surgical suite, where these things are cleaned a lot more in thorough fashion and inspection is done, so that these kind of the complications or potential complication can be minimized. So it still is a working process, and however, it certainly did us a favor in terms of changing our mode of operation and behavior, understanding that this is an issue. So I believe we are better prepared, not just our institution, but nationwide. But yes, that is something to be cognizant about. I guess that's as far as I can tell.
Okay, I think most of the questions are regard to ERCP. These two, probably you can answer them both. Can multiple ERCPs and brushing create areas of atypia in bile duct? And the other question is that, is it true that sometimes sometimes ERCP will make the PSC worse?
Let's see, I hope my brain remembers both questions. So the atypia, by definition, if I'm not mistaken, the definition of atypia basically means abnormal cell. So it's as broad and as generic as it gets. But however, from the perspective of patients, as much as the physicians, when they say there's something atypia about it, it raises a concern from our end of it. So if you do a brushing, what does brushing do? What does it do? It disrupts the epitheliums of bile ducts. So you're creating a micro-inflammatory environment. So theoretically, could it be possible that after multiple brushings and multiple instrumentations and disruptions of the bile duct, that actually there's the atypia reside in that sense? Yes, it could. However, does it promote? I'm not sure if that's the right way of answering that question. And the next question was the multiple ERCP, does that actually progress the PSC? Well, here's the way I can answer, and maybe I should have actually emphasized this before to you. So when you do the ERCP, and then I told you that does the ERCP save life or prolong life, and I said that's a controversial. However, here's one thing that we know, and Bijan can actually comment on this. If you have a dominant stricture, and if you don't treat it, not only the concern is the cholangitis itself, but the progression of fibrosis of the liver itself, which actually causes expedited progress of the cirrhosis itself. So, I think that the benefit of ERCP, if indicated for treatment, clearly outweighs the risk of potential or any kind of foreseeable potential for a development or the exacerbation or the expeditious development of the PSC. So I don't think that's the case. Would you agree?
Yeah, sure. You're right. When you have a dominant stricture and there is a kind of obstruction to the free flow of the bile in the system, and inflammation that it can cause, and also increase risk of infection, can increase actually the inflammation and chance of fibrosis, more aggressive fibrosis in the liver, and makes the cirrhosis worse. I agree with you. So it's better to be all those strictures to be drained. Okay, one question, I think that's for Alok. Steroid helps eczema, why not PSC itching?
Well, the itching in PSC is not necessarily an inflammatory itch. So steroids are one of the most commonly used prescriptions in dermatology, both by mouth or topically with the use of creams or ointments. Steroids can be very, very helpful for the itching of eczema or other inflammatory skin diseases, but so far as we know, the pathogenesis of itching in PSC relates to other mechanisms, endogenous opioids, serotonin, but not directly an inflammatory pathway. So if there are areas of eczema, we can treat it with a steroid, but if it's just diffuse itching, steroids don't necessarily help. So that's why we don't use that.
Yeah, one more question. I found that Pepcid and allergy medications like Allegra help with my itching. Is it typical?
We do often use antihistamines for like Pepcid or Zyrtec or Allegra for itching in other patients. Sometimes it can work, so it's definitely a pretty low risk medication to try, but on the whole, we haven't found that it's been very helpful in patients with PSC. So definitely taking an Allegra and a Pepsid, the likelihood is not high that it's going to harm you, but it might not work very well. So,
Okay, one more for you. You touched on Enzyme and how as promoting liver health. What does it do more specifically?
That's actually a very good question. I can't recall the exact dose that's recommended. There are lots and lots of different preparations that are available over the counter. I think it's always worthwhile starting at the lowest possible dose, seeing if you tolerate it, making sure that you're not getting any side effects from it, and then slowly increasing. I also think it's very worthwhile running it by your hepatologist. There are several active herbal ingredients in wormwood, so we generally need to run it through our interaction checker on our medical record to make sure that it's not going to affect any other prescriptions. So definitely ask your other physicians before you just start taking it to make sure that it's not going to have any bad side effects.
Okay. Question for Dr. Walia. Please comment the study linking Benadryl long-term use with Alzheimer's. That's a question. And can you recommend medications for PSC patients with restless leg syndrome? If you
So Benadryl with dementia, I'm not aware of any specific studies, but there are studies linking sleep aids and dementia. And I don't think we know the causality in those situations. The possible explanation or the plausible explanation could be the drowsiness and the sedative properties with these medications that could be linked with or perhaps be associated with cognitive impairment. So that's the only explanation we know of, but I don't think there's any definitive evidence in terms of causing cognitive impairment or Alzheimer's. Second question is restless leg syndrome, and what are the treatment options in PSC? So first step would be to measure the ferritin levels in these patients. Ferritin is a store of iron, so even despite having normal hemoglobin, sometimes the ferritin levels could be low. So once we measure the ferritin, and if it is low, in particularly less than 50, we replace it with the iron supplements, with vitamin C to enhance the absorption. So that could help in the restless leg syndrome. Non-pharmacological therapy can be effective in restless leg syndrome as well, such as warm or cold compresses. Mentally alerting activities while you're experiencing these symptoms, try to get your brain off of these symptoms, could be helpful. Magnesium supplements, if safe, could be used sometimes. Of course, walking around can be helpful. In terms of other medications, certainly talk to your hepatologist before starting it. There are other medications which could be used for restless leg syndrome, such as dopaminergic agonists, which is ropinirole or pramipexole. We often start at a low dose and go up high as tolerated or as seem effective. But again, talk to your hepatologist before it is started. The other medications are alpha-2 delta ligands, such as gabapentin, that could be used as well for restless leg syndrome. And they are very effective medications, but again, should be used with caution, but it certainly will improve the quality of life with restless leg syndrome.
Okay, Carol, question for you. Is it beneficial to communicate with your doctor via your patient portal prior to your appointment? And raise questions that you have before your appointment.
It's a great question, and I will say that I think it's patient and provider preference. I love communicating with my doctor via my chart, which is our tool here, and it's really helpful because it's easy access. And again, I think it goes back to having a rapport with your doctor, because you know how a brief written communication can be misunderstood. But if you know your doctor and your doctor knows you, it's a great way to communicate. Some physicians will say, email me. You know, so talk about that in the course of the treatment. Talk about the preferred method for both of you. I know that I have an upcoming visit next week, and through my chart, I was given a questionnaire to fill out. It was so easy to do, and now that's done, and my provider is going to have all that information before I even get there next week. So I think in today's day and age, time is really of essence, and we don't have a lot of time on either side to spend. I wish we did, but we don't. So let's take advantage of anything that's going to help us in a very positive way communicate better. It's a great question. Thanks.
Okay, there are so many questions, so many interesting questions. Do people with PSC always have elevated liver enzyme levels, even if they are asymptomatic?
You can answer that better. The most of the times, yes, certain amount of abnormalities do exist, and it's a matter of before and after most of the time. So the most common, the abnormalities that we see, actually, if I'm not mistaken, is the alkaline phosphatase. So that is the indication of the fibrosis within the bile duct, in a nutshell, in a simplistic manner. So number in itself does help you if it's tremendously high, but what we are looking for is a before and after the treatment effect. That goes same thing for the ERCP as well. So when we do the ERCP, it's not necessary that we're looking for this normalization. You know, to be frank, what is normalization? That's an arbitrary number and cutoff that has been used for decades. Having said that, in itself is not as valuable as, again, where was it and where is it now? So the short answer is yes, there's some signs, some mild abnormalities that may be still there undercurrent, but that's not as important as the treatment effect.
Okay, there are several questions regarding melatonin. That if it's safe for PSC patients to take it on a daily basis, and if they use it effective in to other sleep problems.
So the use of melatonin is indicated primarily in circadian rhythm disorders and not so to promote sleep, actually. So circadian rhythm disorders are the disorders such as delayed sleep phase syndrome, where folks tend to sleep late and wake up late, or advanced sleep phase syndrome, where people tend to sleep earlier and wake up earlier. That's the real indication of melatonin. It's really not indicated in insomnia. Some people do use it for insomnia. It's fairly safe, but it's recommended only for shorter periods of time. So what was the second part to the question?
If it's effective in other diseases like.
Yeah. So jet lag disorders or circadian rhythm disorders, that's when we tell people to take it. For instance, if somebody has delayed sleep phase syndrome, which is sort of night owl syndrome, sleeping late, waking up late, we use melatonin and we tell people to use it about maybe 0.3 to 3 milligrams about 5 to 6 hours before their habitual sleep time, actually. And that's where it's most effective as compared to insomnia treatment. It's readily available, used commonly, but again, I'll emphasize it's more so for circadian rhythm disorders.
Okay, that's for Dr. Vij. Are anti-itch creams as effective? And if so, which over-the-counter or prescription?
So there are some really great over-the-counter products available. One that I really commonly recommend is called Sarna, S-A-R-N-A. That's available generally at most pharmacies or drugstores. They're very, very good and helpful for trying to stop that itch scratch cycle. So anytime you get an itch, we try to have you retrain yourself to use a little bit of the anti-itch cream and rub it in so you're not using your fingernails and damaging your skin. The more gentle you are with your skin, the less you're likely to reinforce that pattern of chronically scratching and itching. There are some other good ones. Eucerin makes a great anti-itch cream. Aveeno makes another one called Aveeno Skin Relief. You can definitely use them all over. They generally don't have many fragrances or preservatives, so it's okay to use them even multiple times a day. But it's definitely not easy to slather a thick moisturizer all over your body once a day, let alone even 5 or 6 times a day. So definitely use it more for a spot treatment, and if you can work it into your routine to do it all over once or twice a day, that's a wonderful thing that you can definitely do.
Okay, there is a question. When you're getting an ERCP for a dominant stricture, if you don't want or need a stent, what is the difference or consideration between other two options? Balloon dilation versus any other?
The idea is to maintain the patency. That's the most important thing when you have a dominant stricture. So that of all the devices that's available in terms of maintaining the patency for long duration, bar none, the stent is the right choice if there's a dominant stricture to be treated. If the patient don't want it, obviously that's beyond the clinical choice and the options. But if you are to treat the dominant strictures, let's say you are disrupting by balloons or the catheters that graduated plastic tube, what you have created is an environment temporarily inflammatory because you broke that stricture. Hence, the accumulation of the inflammatory cells reside there more preferentially. When that happens, there's an edema or swelling. So therefore, in itself is a very transient treatment, which will actually results in actually relatively quick closure. So nowadays, this day and age, actually nobody does just balloon dilations and let it be only in a very, very exceptional cases. When we do dilate with the graduated catheter or balloon dilator, the expectation is stents is gonna be there maintaining the patency.
Okay, this is an interesting question. Does weed help relieve symptoms? Any of you?
There are some small studies that dronabinol, a THC medication, can be effective for itching, but it's very small. In Ohio, we don't have medical marijuana available yet, so nobody really knows.
Okay. That's a question. Do we have bioabsorbable stents for bile duct? And if so, what are the problems?
Wow, that really is a really, really excellent question. There is a bioabsorbable stent in esophagus that's actually made by the Czech Republic, and they have done this in a esophageal strictures, whether malignant or benign. The idea is that you insert and you don't have to get out of the procedure for a retrieval. So the issue has been that when you have a stent and you expect this to be dissolved, you would like to have some understanding as to the progress or rate of dissolution. So in other words, if you put it for 6 months, or let's say even 3 months, what's the expectation that this stent will dissolve in a graduated and expected fashion? In a 6 week, it's going to be 50%, and in 9 weeks, it's going to be 75%. That is not the case in terms of that esophageal stricture, that stent, the bioabsorbable stent, and that's one of the reasons that we're still looking for a polymer that will give you a predictable rate of dissolution. So for the bile duct, although that is on the horizon, hopefully from the device company, we don't use those bioabsorbable biliary stent.
Okay, just another question for you. If stricture detected at the time of ERCP, is it usually treated at the time of that the time is discovered, or scheduled?
That goes back to the idea of, if you will, that the concept of a tree. So if your stricture is in the trunk, so by definition, yes, dominant stricture, you ought to treat that with the ERCP. If your strictures are diffuse and it's throughout those small branches intrahepatics, ERCP does not serve a therapeutic purpose.
It's for Carol. Can you give some specific strategies that are effective in building rapport with your medical team?
Great question. So I would start in a conversation that really gets to know each other. You know, how do you like to communicate? What's most important to you? I would also think very clearly about what is, as a patient, what's most important to you, and share that with your doctor. Let your doctor get to know you, and that builds rapport, just as in any relationship. This relationship between a doctor and a patient, especially when there is a long-term illness that you're going to be communicating all the time, it's so important. And I will say the same is true with your relationship with your primary care doctor. Whether it's a specialist or not, that relationship with your primary care doctor maybe is even more important, because that person needs to know when to send you to a specialist. So I think because we are all so different, I would recommend spending some time telling your doctor who you are and what's important to you. Now, of course, on the other side of the coin, I say the same thing to our providers. Make sure that you take the time to get to know your patient. But I'm a firm believer in that this is all up to all of us. We're partners here, so own it and just make sure that you take the time to let your doctor know you as much as asking your doctor to tell you a little bit about him or her.
Okay, there's a question, ERCP question again. Is the management of PSC, in the management of PSC patient with dominant stricture, does ERCP play a different or larger role regarding cholangiocarcinoma surveillance? And if cholangiocarcinoma can hide on MRCP and you need to have ERCP?
The first question is yes, because where usually the cholangiocarcinoma develops is those dominant strictures, if I'm not mistaken. So every time you have this dominant stricture and when you have a ERCP done, what you're also looking at is once you take the stent out, the progression in terms of length, in terms of lumen size. If there's any question of it, you need to brush that, you need to biopsy that, you need to get something that tells you one way or the other whether there's a disease progression or not. So that yes, ERCP play a larger role if you use dominant stricture, even in terms of concern for the cholangiocarcinoma. Going back to the second questions about MRCP and hiding, that goes back to the accuracy of the test. And as I said before, where the MRCP is weaker than ERCP, perhaps will be the early part of the PSC as well as the patients with the cirrhosis. So can it hide? Theoretically, yes. But if you have a cholangiocarcinoma, most of what it infers is that you do actually have a quite advanced case of PSC as well. So as to the theoretically yes versus the reality as to whether that is a real problem, not necessarily, because if you actually do the MRCPs on a surveillance purpose, if you do, when you notice something different, that's when the ERCP comes in. So still the MRCP serves as an initial tool that discerns something abnormal, something developed, or is it status quo or not.
Yeah, now that we're talking about MRCP, there's a question that if there is a need for prophylactic antibiotic at the time that we do MRCP, like ERCP, but probably not. The MRCP is not an invasive procedure, it's just an X-ray study, and you don't need prophylactic antibiotics. Then let's see, some of these questions are. Okay, is there any problem with gadolinium used in MRCP in PSC patients?
Wow. That's a great question. The radiologist should answer the questions. Gadolinium's issue was the nephrosclerosis, as to whether there is a individual or specific interactions with the PSC with the gadolinium. At least I'm not aware of it.
Okay, there is another question, post-transplant PSC, if there are fever and chills and patient is allergic to Cipro and penicillin, what to do? I think there are a number of antibiotics that I think I'll leave it for the physician who is treating you to choose which one. Of course, there will be a lot of limitation in the choice of antibiotic, but there are still antibiotics that you can use. Do you recommend the fish test in ERCP? I think this is a pathology.
I think Dr.
histology.
Carey's up there, and he can answer that question better than I can. The FISH test basically is a fluorescent-based test, and that has increased the sensitivity quite a bit. So in our institution, and when there is a question of a disease progression in strictures, our hepatologists routinely ask for it, and we deliver it, because it's just one additional brush cytology. It's not that hard for us.
Okay, there are, well, I think we talked about the use of medical, I'm sorry, this is another. Does the use of medical marijuana rule you out for transplant? I think this is a big discussion depending on where you live, but still in many states, yes, it is a rule out. But time will tell us in the next year or two. Okay, I think Carol probably can shed light on this one. How does the Cleveland Clinic reimburse MDs for time answering emails and questions?
No, Carol cannot respond to that one. But it raises a really good question, and that is, how do we fit it all in? And that's why I said earlier, this is not easy for anyone on either side of the partnership in terms of the emotion that we deal with, the dedication that we deal with, the commitment that we deal with. And so anything we can do to make the relationship better, to make the environment better, to make it more supportive is going to be beneficial. And that's why I think communication is so important. And that's why I think what you all are doing is so important. This is what advances where you are and the progress that you're making, and I just so applaud you. I will say that I've been at so many conferences, and there are usually maybe 5 or 10 questions that come up. These questions have just been coming up routinely through this whole panel discussion, and I think that's significant, and I applaud you. That will carry you far. In answer to the whole reimbursement issue and the direction that medicine is going in and healthcare is going in, that's a huge one, and I certainly cannot address it. I know it becomes a barrier at times, and we all have to work toward overcoming those barriers.
Okay. Well, unfortunately, we are right at 10:15, and we need some time for break and then starting next session. There are still some more questions. Some of the questions were not quite related to the panel, so I kept them here. We can answer them in person during the break time. Thank you so much for staying here. It's a great meeting.